Welcome everybody to lecture 2 of 10 for this week. For this one, we're going to cover respiratory pharmacology in the transport environment. And I want this to be practical and like readily available and usable. I've organized this lecture around the question every transport clinician should ask about every respiratory medication. What is it? How much am I giving? And why am I giving it? We'll move through parasympatholytics, adrenergic bronchodilators, inhaled corticosteroids, nonsteroidal anti-asthmatic agents, um, mucolytics, anti-infectives, inhaled nitric oxide, heliox therapy, and specialty nebulized agents like heparin and lidocaine. By the end, you'll have a mental framework you can use on each transport. Let me walk you through today's objectives so you know where we're headed. First, I want you to understand the mechanism behind each respiratory drug class. Not memorize every detail, but understand why a beta agonist exists and why it does what it does versus an anticholinergic medication. Second, I want you to know how typical dosing ranges for the agents you'll use most, especially albuterol, ipratropium, inhaled corticosteroids, etc. Third, I want you to recognize the key adverse effects to watch for during transport because you may be one of the first to catch them. And finally, I want you to be able to apply a what, a how much, and a why framework when you encounter any respiratory medication in the field, including the specialty agents most clinicians don't usually think about until they're starting nitric oxide delivery with a patient who's mechanically ventilated at 3 in the morning on icy roads and things like that. Um, So pharmacology for respiratory therapists is a full semester class, 3 credits, 3 hour lecture that I've taught for a handful of years each week, and so truncating it into a 40 or so minute lecture is tough, but um, I'll give you the bare bones of what you should know. So let's start with the backbone of acute respiratory pharmacology, and that is bronchodilators. So bronchodilators are divided into two different types. So short acting and long acting for both beta agonists and anticholinergics. The short acting beta 2 agonist or SABA is albuterol, and that's the first line rescue medication in asthma and COPD exacerbations. For adults, you'll give 2.5 to 5 milligrams by nebulizer every 20 minutes times 3, usually in route, if that's indicated. Or if you've got a status asthmaticus patient, you could run it continuously at anywhere from 10 to 20 milligrams per hour based on the length of your trip. For a PEDS patient, start with, usually PEDS patients can just get a standard dose of 2.5 milligrams of albuterol. You can do it by weight, so like 0.15 milligrams per kilogram for a minimum of 2.5 milligrams. Um, Ipratropium or Atrovent is the short-acting anticholinergic, or a SAMA. It's a muscarinic antagonist that is often used in conjunction with albuterol, especially for patients with COPD exacerbations, and that comes in the form of DuoNeb via small volume neb, and that's 2.5 milligrams of albuterol and 0.5 milligrams of Atrovent in a 3 ml solution. Um, Long-acting agents are typically not going to be administered in the transport environment. Long-acting bronchodilators, your beta-2 agonists like formoterol, salmeterol, your long-acting muscarinic antagonists like ipratropium, or I'm sorry, that's a lie, that's a short act. Tiotropium, um, or Spiriva, aclidinium, Tudorza. There's a whole mess of them. The list for bronchodilators keeps growing by the year, and it can be a lot to keep up with. But the staples that you'll give, albuterol, Atrovent, Duoneb, those are not going away. In addition to bronchodilators, and I mean bronchodilators for us, covers 2 weeks and 6 hours of lecture. I'm not going to go into a lot of the autonomic nervous system, but the just really briefly, just for kind of a review. I know you've had this in A&P, but um, on the one side, you've got the parasympathetic system, which is your autonomic, um, automated. So your salivation, lacrimation. We've got a SLUD acronym. The U is urination, and then defecation. So all of the internal processes that we don't know that we don't feel happening. Um, the the parasympathetic side, um, with acetylcholine as the neurotransmitter. Um, the medications that we give block the transmission of acetylcholine at the nerve end sites, and those allow for bronchial smooth muscle relaxation. They work on the M3 receptor at those terminal end sites, or the muscarinic 3. So they are also called anti-muscarinic medications. So those are your SAMA, short-acting muscarinic antagonist, LAMA, long-acting muscarinic antagonist, and the only SAMA is your ipratropium or Atrovent, which is almost always used for COPD in conjunction with albuterol in the form of Duoneb. And then patients are often prescribed long-acting muscarinic antagonists for control, and prevention of exacerbations. And those are things like Spiriva, Tudorza, Incruz, Ellipta is a new one that is often used, and things like that. The the muscarinic antagonists, so your Atrovent, those work completely differently from your albuterol and the short-acting beta-2 agonists. Albuterol falls under the sympathetic side of the autonomic nervous system. So that's your fight or flight, where heart rate increases, respiratory rate increases, blood pressure increases. It's adrenaline, epinephrine. The sympathetic side contains catecholamines. Won't go into that, but there's a lot more to it. But on the sympathetic side, at the norepinephrine is the neurotransmitter, and the bronchodilator, like albuterol that we give, acts on the beta 2 receptor at the nerve end sites in the sympathetic part of the autonomic nervous system on the airway smooth muscle, to cause bronchial dilation or relaxation. So, relaxing of the smooth muscles in the airways. Um, because they act on the beta 2. You'll hear them called beta 2 meds. Do not confuse them with beta blockers. Those are completely different. Um, but your beta 2s make it a SABA and LABA, so short acting beta 2 agonist, long acting beta 2 agonist. The only real short acting beta 2 agonist is albuterol. There are many long-acting beta-2 agonists, salmeterol, formoterol, bolodaterol, vilanterol, etc., etc. Most of those are combined with other medications in the form of inhalers. So there are some SABA-SAMA combos, and there's also a slew of inhaled corticosteroids and long-acting beta-2 agonists that are combination meds. And I don't foresee you having to give any of those in route, but just to have an idea or general understanding that bronchodilators are divided into two different groups that act on different parts of the airway smooth muscle. Moving on to the slide that we've been on, inhaled corticosteroids. So you may end up giving an inhaled corticosteroid in route. There are indications for that. So inhaled corticosteroids, or ICS, they are fundamentally different from bronchodilators. They treat inflammation, not active bronchospasm. So they are for airway inflammation. Um, Inflammation of the airway can cause swelling. It can cause mucus production. It can cause bronchospasm. But the ICS meds do not treat the bronchospasm. They treat the inflammation. So a lot of times they're used in conjunction with a bronchodilator. So that they'll get albuterol and then like Pulmicort, and that's a pretty standard regimen, especially for COPD patients. Um, Pulmicort is the most popular one, I would say. Budesonide is the generic. So top left in the table, budesonide is Pulmicort. That comes in either an inhaler or a small volume nebulizer. Um, that is sometimes used in croup, sometimes used in ICU airway management protocols. There are many other corticosteroids. They end with either "-one" or "-ide". So fluticasone, which is Flovent, beclomethasone, which is QVAR, mometasone, which is Asmanex. Those are all like scheduled controller medications um, that patients need to get on schedule either once a day or twice a day for them to work. Um, but they're not going to open any, bronchospastic airway in the next 10 minutes on your run. So don't confuse inhaled corticosteroids and their effects with systemic corticosteroids, or oral or IV. Your prednisone, dexamethasone, solumedrol, things like that. Those should be given, either orally or IV for like acute asthma exacerbations in combination with a bronchodilator like albuterol. Um, that's something that my students always have trouble with. ICS meds are controller medications only. One of the fastest growing, I guess, groups of respiratory medications in the form of either inhaler or you see a syringe there, so IM delivery are non-steroidal anti-asthmatics or anti-asthma agents. Those include leukotriene modifiers, cromolyn sodium, which is a mast cell stabilizer. Biologics are becoming much more popular. The three listed here: omalizumab, mepolizumab, and duplo. That's a new one. Dupilumab. Um, those are the most fun to say, for one, but they're also growing in number. Um, but good to be aware of them, especially if you get and report that a patient is on one. So, nonsteroidal anti-asthma agents are primarily outpatient and specialist territory, but you need to know about them because your patients are likely going to be on them. Montelukast, which is singular, and Zafirlukast, which is accolade. That could be wrong. Darn it. Sorry. um, those block the leukotriene pathways. They reduce inflammation and bronchoconstriction in allergic and aspirin sensitive asthma phenotypes. These are predominantly used for asthma. Cromolyn sodium is older and rarely seen anymore, but some patients may still use it for like exercise-induced bronchospasm. Um, Biologics are really coming up. We've got omalizumab, um, which is my favorite one to say, and all the umabs. Okay, those are really a recent revolution in severe asthma care. They are targeted therapies given every few weeks by injection, and they can dramatically reduce the frequency of asthma exacerbations. None of these are rescue medications. If you've got a patient on a biologic who's decompensating, your job is to provide the rescue care they need, and communicate that to the receiving team that these medications exist, but you'll be giving them albuterol or duoneb. Switching gears to mucolytics and airway clearance medications. So mucolytics and airway clearance adjuncts are tools really for specific patients, mainly for cystic fibrosis, bronchiectasis, and patients with inhalation injuries. The three listed here. So we've got N-acetylcysteine, that is Mucomyst. You've probably heard of Mucomyst. It's terrible. It smells like rotten eggs. It'll stink up the back of your bus or the entire um, aircraft. Um, it's really toxic. Always wear gloves. Always wear a mask when you give acetylcysteine or Mucomyst. Mucomyst has had a love-hate relationship with providers over time. Historically it's been used a lot, but in recent years it kind of went away because lots of studies show that it didn't really do much except really irritate the airway and make people cough, and it was more of a disturbance than anything else. However, it has gained traction in the last few years, and we're seeing it more and more. But what acetylcysteine or mucomyst does is it breaks down the disulfide bonds in mucus to reduce the viscosity of it. Um, and it yeah, when you nebulize it, it smells it's a sulfur smell. It smells like rotten eggs. That can actually trigger bronchospasm. So you always want to pre-treat mucomyst with albuterol and have suction ready. That is a key takeaway if you've got someone with a lot of secretions. Mucomyst is also used for for Tylenol overdoses. That's usually in liquid form that they drink, and it tastes like it smells. So yeah, I always tell my students if you're going to OD, don't do it on Tylenol because you won't like you won't like the result. Um, Second one is Dornase alpha. That's pulmozyme. That's an enzyme therapy that cleaves the DNA in like really purulent secretions for cystic fibrosis. So it's really only indicated for cystic fibrosis. If you're transporting a CF patient who's got a scheduled dose for pulmozyme, try to continue it. It won't be the end of the world if you don't. The other one, or I guess two, hypertonic saline or hypersal, that is essentially just a saltwater solution that is nebulized, different percentages of the salt. So 3% or 7% are the most common ones, but you may see other percentages. Those work by osmotic draw, pulling water into the airway lumen and thinning secretions. Um, Again, though, it can trigger cough and bronchospasm, and really, it's just like an airway irritant. I would argue that en route, if you're considering using a mucolytic, um, they have to be really bad. It would have to be an emergent thing, if they've got mucus plugging or if you can't ventilate, um, because um, the side effects kind of outweigh the risk outweighs the benefit in the transport environment in most cases, I would say. Similar to the mucolytic and the NSAA categories, anti-infectives for respiratory transport, both systemic and inhaled. Um, those are not going to be as frequently used. Most of the time, like when you think about anti-infectives and respiratory transport, you're thinking about systemic agents, ceftriaxone, azithromycin, piptazo, vancomycin, things like that. That the team that is sending the patient has already started. Um, your job, of course, is to make sure that they're running on schedule and infusing safely. Uh, Inhaled anti-infectives are a completely different category, and they're primarily used in cystic fibrosis and bronchiectasis patients with a chronic Pseudomonas colonization. Inhaled tobramycin or Toby is the most common. That's 300 milligrams nebulized, typically on an alternating monthly cycle with aztreonam or Caistin. Um, it's not going to relieve dyspnea at all during the transport. But for a patient on a chronic regimen who needs continuation, it matters that it's given at appropriate times. Um, so, I mean, you'll need to ask yourself whether the timing is critical during the transport window, whether you've got a compatible aerosol delivery system, because some, like in the picture here, that middle picture on the right is a specific nebulizer for Caistin, um, and a standard small volume nebulizer will not nebulize it properly, so it makes it a little yeah, not great for transport. Um, Basically, the um, the inhaled anti-infectives are are only going to be administered en route, like if you're on a long transport and it's a scheduled time for the patient. But the takeaway is not to confuse those with systemic anti-infectives because they do not in any way work in the same ways. Switching gears again to inhaled nitric oxide, I added it here instead of with the mechanical ventilation lecture, just because it is, as a gas, technically a drug, so it falls under pharmacology. Um, but INO is often used in transport connected with somebody who is on mechanical ventilation. So you can run inhaled nitric oxide with a conventional ventilator. You can run it with a high frequency ventilator. And it's operationally one of the most complex medications that you'll encounter. The drug itself is straightforward. It's a selective pulmonary vasodilator that dilates vessels in ventilated lung segments, which improves oxygenation and reduces pulmonary vascular resistance, or PVR. Um, we typically start around 20 parts per million and then titrate from there. The indications for inhaled nitric oxide are neonatal PPHN, or persistent pulmonary hypertension of the newborn, um, acute RV failure states, but the greatest risk of INO that's important to understand is the abrupt discontinuation of it. Um, if the INO delivery system fails, the patient can suffer severe rebound pulmonary hypertension and acute hypoxemia within minutes. So it's really important to make sure that the system works and that you don't just wean them off. I would argue that, like, you would if you have a patient who's on nitric oxide on a transport, do not wean the nitric oxide amount. Let let the hospital take care of that. You can increase it, that's okay, but never titrate it. Um, and without having one, we don't even have one in lab. But the cylinders are all different depending on the manufacturer. There's usually a backup delivery system, so it's a complicated setup. With INO, you always want to make sure that you have a methemoglobin monitor running, and always have like a contingency plan if something were to go amiss. Other pulmonary vasodilators are like Velitri, um, oh boy, epoprostenol, and those are the two big ones. But inhaled NO is most common, especially for neonatal transports. The best way to determine whether a patient needs inhaled nitric oxide or some form of pulmonary vasodilation is to do a pre and a post ductal SAT. So put the pulse ox on the right and put another one on the left. If there's a difference, usually the split should be around 10% to warrant something like nitric oxide. But that is the key distinguishing factor for starting INO. One other gas mixture that you may very well use on transport is helium oxygen, so Heliox. Heliox therapy is actually very simple. The physical principle is simple. So helium is much less dense than nitrogen and oxygen. So a helium oxygen mixture has a lower overall gas density than air or standard oxygen. So lower density means that less turbulent airflow resistance, which reduces the work of breathing, is there. So basically, it allows for the oxygen to pass through places where it otherwise would have trouble in the upper airway, to better effectively deliver oxygen to the lungs and then the tissues. Um, the oxygen binds to the helium very well, and the helium just kind of takes it with it. Um, in the case of upper airway obstructions, the most common blends are 70-30 or an 80-20 helium to oxygen ratio or mixture. Um, I think of Heliox as temporizing therapy for turbulent flow problems. So, upper airway obstruction, croup, post extubation stridor, severe bronchospasm in some cases. It does not treat the underlying cause. The critical limitation is the FiO2. So, as your oxygenation needs rise, the helium fraction has to fall. And below about like 60-40, the density benefit pretty much disappears. So Heliox is not great for patients who are hypoxemic um, due to something other than an upper airway issue. Heliox is great for upper airway obstructions. Um, we've used it in patients who've got tumors, and lots of time in croup, epiglottitis, um, severe asthma exacerbations, or status asthmaticus situations, things like that. Um, on the road, though, device compatibility is a major transport issue. Most of the standard transport vents and flow meters aren't calibrated or equipped for Heliox. And if they're not, then they'll underread and or misdeliver it. So, verifying device compatibility and the gas supply before departure, and somebody who you might suspect could benefit from Heliox is very important. In the last decade or so, there have been other nebulized agents that we're seeing more routinely. This slide covers the specialty nebulized agents that you should know about, even if you're not using them all the time. Nebulized heparin is a big one. Nebulized heparin is most commonly seen in burn center protocols for inhalation injury. It helps to prevent airway cast formation, the fibrinous cast that can completely obstruct bronchi in the hours after smoke inhalation. Um, Dosing is institution specific. Usually it's around 5 to 10,000 units nebulized every 4 hours. And it's almost always paired with NAC and albuterol. Um, but anybody with smoke inhalation, any inhalation injury, um, think about nebulizing heparin if you have it on board. Lidocaine is another big one now. Nebulized lidocaine is used for airway topicalization and cough suppression in procedural settings, like bronchoscopies, certain intubations. But remember that it reduces airway protective reflexes, so the patient selection and monitoring matter. Um, I don't know that lidocaine would be often used in the transport environment. This last one, though, is, and you've probably given it many times, racemic epi. So racemic epinephrine, asthmanephrine, whatever you want to call it, that is the most used medication for upper airway constriction in croup and post-extubation stridor, sometimes epiglottitis. Um, it works. It's in the same like ballpark as albuterol because it works on the sympathetic side of the autonomic nervous system, and norepinephrine being um, the neurotransmitter, your catecholamines, norepinephrine, epinephrine, dopamine. Racemic epi is a derivative of straight up epinephrine. Um, that works through alpha effects, so it's an alpha 1 medication, and that uses or it works on those transmitters to reduce edema. Um, Always watch for rebound swelling, tachycardia. Racemic epi is it's very quick acting. You'll notice within minutes if it's going to have any positive effect or impact on the patient. Um, and it has a high side effect protocol, especially with tachycardia and heart palpitations and things of that nature. The typical dose for racemic epi is zero point 0.5 mLs of a 2.25% solution. That comes out to 11.25 milligrams. You don't need to know that. It's sometimes in an undiluted vial, so you have to chase it with some normal saline in the nebulizer cup. Um, but they do make it in diluted form as well in a 3 ml vial. There's nothing worse than having a patient crash on you while you're en route. And if it's at the hand of any respiratory medication that you give, that I can imagine can be even more anxiety inducing and stressful. So let me walk you through the adverse effects that are most relevant to the transport environment. Beta agonists, particularly at high doses, if you're using it for status asthmaticus, if you've got a continuous albuterol running, or if you're giving double duos to a COPD patient, or more than just a standard 2.5 milligram albuterol to an asthmatic. Always be on the lookout for tachycardia, for tremors, for anxiety, and they can also cause hypokalemia. At very high continuous doses, you can also see lactic acidosis, which can really confuse your interpretation of the point of care lactate in a septic appearing patient. Just something to keep in mind. Uh, Anticholinergics on the other side of the bronchodilator spectrum. Those are generally well tolerated, your ipratropium, Atrovent, but still watch out for tachycardia. Um, Sometimes urinary retention, but that probably wouldn't matter much in a transport situation. Um, Inhaled corticosteroid um, therapy, if you were to give Pulmicort, anything like that, that does not typically cause any immediate problems in acute care, but it can cause hyperglycemia and some immunosuppression. So your more critically ill patients on systemic steroids, be wary of that. Always, 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 when you if and when you administer an inhaled corticosteroid, um, always rinse their mouth out with water. Sponge it if you've got sponges. If they can drink, have them take a drink. Swish and spit. Um, Inhaled corticosteroids very easily cause oral thrush, and nobody likes that. Mucolytics. Mucolytics can trigger bronchospasm. Um, Pre-treating it with a bronchodilator and having suction at the cot side or stretcher side is very important. Um, And then your device-dependent therapies like your INO and Heliox, those are more of logistical risks than pharmacologic ones. The only major pharmacologic risk is stopping nitric oxide therapy cold turkey. Otherwise, usually it's a troubleshooting issue with something um, with the mechanism that goes wrong. All right, so that's a lot of random information over the course of 40 minutes, and let's try to pull everything together. So for every case, try to answer three questions. What are you giving, how much, and why? In status asthmaticus, give albuterol and ipratropium together, continuous neb if needed, plus systemic steroids because you want rapid bronchodilation and early anti-inflammatory therapy, both at the same time. In a COPD exacerbation, it's the same bronchodilator pair, so albuterol and atrovent, or duoneb, which is the um, nebulized version of them together. Um, but be careful with oxygen delivery for COPD. Try to titrate to a target saturation of 88 to 92 percent in order to avoid, stunting the hypoxic drive in a chronic CO2 retainer. For your cystic fibrosis patient with lots of secretions, follow the sequence of, give a bronchodilator like albuterol first to open the airways, then give a mucolytic to thin the secretions, then some airway clearance if you have the time and the means. And then for your PPHN patient on nitric, um, bring it back to the delivery system. What is it? How much is running? 20 parts per million, and think about why you should not just stop it or titrate it on your own, especially without a specific order. Let me close with the most important concepts from this lecture. Respiratory pharmacology and transport is about matching the right drug class to the right physiology, and that requires knowing whether you're treating bronchospasm, inflammation, secretions, infection, or even pulmonary vascular resistance. Your acute tools are your short-acting broncho or beta 2 agonists like albuterol, and your anticholinergics like Atrovent. Everything else is either a controller therapy or maintenance therapy that you're continuing or on a schedule, or a specialty therapy like heparin, lidocaine, etc. Mucolytics, inhaled anti-infectives, Heliox, INO, those all have important roles in selected patients, but they come with device dependencies and adverse effects that require a lot of preparation. Um, but the single most important takeaway, though, is that drug knowledge itself is only half the battle. Understanding the delivery systems, the different types of nebulizers, patient monitoring, recognizing adverse effects, and having contingency plans are what keep your patients safe during transport. Know what you're given, know how much and why, and know what to do when something goes wrong.